Thank you, world, for being with us. We have people in attendance in Dayton, Ohio, and for tonight's program, we have Horizon Therapeutics. So I want to thank them, and I hope you all do too, and that's great, all right? We can't do these programs. We cannot do these programs without the pharmaceutical industry supporting us, and we thank them for doing this for us. And we are here, fortunately, tonight with the very, very busy Dr. Aaron Boster. And Dr. Aaron Boster is going to speak with you about, well, he's going to speak about fatigue and pain and cognition, all right? Maybe a little bit about speech and how that affects multiple sclerosis, all right? He's also going to speak with you about disease progression. He's going to speak with you about current new MS treatments. He's going to speak with you a little about NMOSD, and I know that most of you don't know what it is, but you will know what it is after he speaks with you. And also, he's going to speak with you about a few other things of his own choosing. Okay, so it's a surprise to me. I can't wait to hear it myself. All right, that's right, and we're all going to learn tonight. So, without further ado, I want to introduce the man from Ohio, the doctor that so many people like to come and listen with, Dr. Aaron Boster.
There you go. Howdy. My name is Aaron Boster. It's an absolute pleasure that I get to be here with you tonight. I'm really excited to learn about MS with you and talk about something that I think is really, really important in 2022, almost 2023. The concepts of self-advocacy and how do you live your best life despite having MS. We learned something during the pandemic. We learned that we have to become shepherds of our own healthcare. We have to become selfish, and we have to, in some cases, take on responsibilities for our own care. And so today, I'm going to talk to you about how to do that. And I put my entire lecture on this napkin. All right, I hope I don't have to sneeze. So starting off, the process of living your best life despite having MS starts with being diagnosed with MS. I haven't met a family with MS who doesn't have a story about the process they went through to get diagnosed. And it's not always like a very nice story. And a lot of times it's a nasty introduction into healthcare. Now, I want to share with you that MS is not a feeling, it's not a I don't know what. It's a diagnosable phenomenon, and I should be able to prove it to you. So if you have been diagnosed 20 years ago, if I was the one that diagnosed you, wherever that may have occurred or when it occurred or with whom, your clinician should be able to prove that to you at any time. Any one of my patients can say, Dr. B, show me that I have MS, and I better be able to demonstrate how I came up with that. Now, simply put, there are 5 elements to an MS diagnosis, and I want to go through them with you just very, very briefly. The first element is your story. We're listening for MS attacks, flares, exacerbation, relapses. We're listening for a sudden or subacute onset of something bad happened, and I tried to hide it from my wife, and after 2 days I had to come clean, I couldn't feel my leg. Right, so attacks. So we're listening for a story of attacks, or we're listening for a story of progression of disability, right? Those are the 2 things that we're listening for when we're trying to figure out a diagnosis. The second thing that we do after we take the history is we do a neurological examination. So I like to call that the MS Olympics. That's where we make you do all this kind of stuff. And what we're doing is we're testing out the different parts of your nervous system to compare them to what you just told us. So if you tell me that you can't feel your leg, when I do sensory testing, I'm checking to see if your leg is feeling weird, right? So those things jive. The third thing that we do to diagnose MS in the modern era is we put your head in a really tight tube, which is super, super loud. I'm very claustrophobic, so even talking about the MRI scanner makes me want to give you Valium. And the MRI is a very powerful biomarker. We don't diagnose MS in the modern era without the use of the MRI typically. Number 4 is a spinal tap. Now, in the modern era, most MS patients do not need a spinal tap for diagnosis. But when there are questions on the table, the spinal tap can be very, very helpful. Number 5 is my fave. Hey, Aaron, I'm Aaron. Prove it's nothing else. So I have to make sure that there's nothing else going on. Show of hands if you're familiar with a cousin of MS called NMO. So not many of you are familiar with the cousin of MS called NMO. So when I was in training, my mentor taught me NMO is the cousin of MS that you never invite to the family reunion. Like literally everybody agrees not to tell them. NMO is a condition that's similar enough to MS that doctors can be tricked. And so I'm going to spend 2 minutes with you and just very briefly talk to you about some of the differences between MS and NMO. Both of those conditions involve the central nervous system, brain, spinal cord, optic nerves. Guys, shut up. And both of them can involve brain, optic nerve, spinal cord. But MS affects more surface. It affects more geography than NMO. NMO tends to mostly affect the optic nerves and the spinal cord and leave other parts of your brain more or less alone, right? And that can be really tricky because both people can have optic neuritis. So how do you tell the difference, right? There's a couple key differences. Your story might not help you sort it out. Your exam might not help you sort it out. Remember I said there's 5 things for MS? We're going to do the same things for NMO. But the third thing, the MRI, looks different. And you need to make sure that your neurologist is looking at the scan. And they should be able to demonstrate to you why. They need to be able to demonstrate to you why the MRI looks like MS or why it looks like NMO. Because I can tell differences on the MRI. The fourth thing, spinal fluid. We generally do not see positive spinal fluid with NMO, where we very oftentimes see it with MS. And member number 5 for MS was prove it's nothing else. There are blood tests for NMO. So every MS neurologist, in my opinion, should be checking NMO antibody and MOG antibody to make sure that the patient doesn't have a cousin of MS. Because the medicines that we use for MS don't work very well in NMO, and kind of vice versa. So making sure that the diagnosis is ironclad is really, really important. Now, as we spend the next hour of your life together, we're going to do something which is most commonly done in like churches and big community centers, a game called bingo. So look on your table, and you're going to see my ugly mug on a piece of paper. And then you're going to see all the things that Stuart thinks I'm going to talk about. So if I talk about one of them, I want you to check it off and say it out loud. And we're going to see who can check off all the things first. Now I'm waiting, because if you read it, I just went over 2 or 3 of them, but nobody's saying nothing. So I'll give you a hint. If you look at the bottom, there's something that says NMO. So you could say, NMO! Oh, good job. All right, excellent. So let's jump into a discussion about what we do once we're diagnosed with MS, how we move forward to live our very best life despite having multiple sclerosis. And it starts with setting goals. When I meet a family and I'm diagnosing MS for the first time, I give them homework. The first homework assignment, I tell them, is the very most important. And we can actually try it right now. Take that bingo sheet and flip it upside down. Whoever happened to have the bingo sheet in front of them, that person holding the pen, I'm going to ask you to do the same homework that I ask my patients to do. Write down 3 to 5 long-term life goals. So take a second and do that. Write down 3 to 5 long-term life goals. Just by way of example, I'll share some of mine. So one of my Aaron Boster life goals is to work on being happier. Like I'm trying to cultivate happiness in my own life. That's a thing, that's a life goal of mine. It's not always been a life goal of mine, it's something new that I'm trying out, and so far so good. A second life goal is to see the Boster Center for Multiple Sclerosis flourish. I started my own practice. We opened up 2 days before the governor of Ohio saw fit to close the state of Ohio with the pandemic, March of 2020. We all remember that. I'll tell you what, it's actually been really awesome, and I'm so proud of my team. And it's really exciting to be taking care of patients in Central Ohio this way. And so I want to see that flourish and do well, and that's one of my life goals. A third life goal of mine is to watch my children grow up to be positive members of society and lead meaningful lives. And as a dad, I want to try to help with that. So those are my life goals. So some of you maybe wrote down your life goals. And when we're in clinic, I actually write those life goals in the chart. Like I take this stuff really seriously, and I'll throw it in your face. I'll say, you said 4 years ago that you wanted to climb Monte Picchu. How are you going to climb a mountain if you don't do physical therapy? Why don't you want to do physical therapy, right? Because we need to center ourselves around your goals. to live our best life despite having MS, I don't want to let MS make very many decisions, right? And so it's a very important conversation. Why? The reason why is because I know how to beat up MS. I read books about how to beat up on MS. I can teach you how to beat up on MS. I can't tell you why. So you tell me why. We're a team, all right? And you're a U expert, and so I need you to tell me what it is that we're fighting for. Fair? Very important way to start things off. Now, once we establish the goals of life, now we can turn our attention to goals of treating MS. So I treat to a target. I have a target that I'm treating to called NEDA, no evidence of disease activity. Show of hands if you've ever heard of NEDA. Some of you have. Awesome. NEDA is a way of saying my goal when I'm treating MS is that I don't want to see any attacks. We don't want any more attacks. That's the goal, no attacks. The goal of treating MS is that your new MRI has no new brain damage, no new spots on future MRIs. That's a goal of treatment. The goal of treatment is that your brain shrinks at a normal rate, just like all other adults. It doesn't shrink too fast. And lastly, I want your examination to stay exactly the same as it was last time I looked at you. Those are the goals. NEDA. And that's called NEDA 4 because I listed 4 things. Now, if you said, well, gosh, Aaron, that sounds lovely. What's the likelihood that we can do that over the next 30, 40 years when you treat my MS? I would say about 0. And you would collect your purse and think, okay, I'm going to go find a real doctor and want to leave. But I would ask you to stop because I want to explain it's a target. It's a goal. So it's a lot like national championships in basketball. Now, you'll be very surprised by this, but it turns out I've never played basketball. It's true. But I've watched people play basketball, and what I learned was there's this big tournament in March where 64 coaches tell 64 groups of young men that they're all going to win national championships, which means, technically speaking, that 63 coaches are lying, right? Because only one team gets to win. No. The coaches are sharing their goal, their target. Gentlemen, the target is national championships. What he's really saying is he's saying, gentlemen, we will conduct ourselves like champions. We will sleep like champions. We will eat like champions. We will practice and exercise like champions. We will study and pray like champions. And then we'll see how it shakes out. Now, if they play the first game and lose, they don't shoot the coach and disband the team and send all the kids home from college. No, they do a root cause analysis and say, you need to pass the ball to you, and you need to stand over there, and you need to go back over there. And then they go back out on the court, and they see what happens. If I can hold a patient in NEDA, no evidence of disease activity, for 2 years, the statistical likelihood that their exam stays still for the next 7 years is almost 80%. And that's a statistic that I really like. So that's my goal when I'm treating MS. Now, what I would like to do next is share with you how do we operationalize that goal, right? Because chit-chat's lovely, but that's not how we get things done in clinics. So what do we actually do to work on that goal? I divide my thoughts into 3. There are 3 things that we do simultaneously to beat up on your MS. The first one is to treat attacks. So an attack, a flare, an exacerbation. This is when a naughty autoreactive white blood cell, which is in the bloodstream, crosses the blood-brain barrier into the central compartment, where it then sees part of your brain or spinal cord or optic nerve and thinks it's looking at a foreign invader, thinks it's looking at a bad guy, and it attacks it. And it causes that part of your nervous system to short circuit, like it literally doesn't work. And if that part of the nervous system is your eye, you're not going to see very well. If that part of your nervous system is the spinal cord that controls your legs, they're going to be numb and tingly, or they might be really weak. That's an attack. And we don't predict when you're going to have an attack. My mentor used to tell people, we don't worry about the flat tire we don't yet have. Right? Nobody drives down the freeway and says, honey, do you think the front left tire just blew up? That's not a conversation. Because if the front left tire blows up, you don't need to ask. It's very, very clear. And when you have an MS attack, it's not subtle. And after a couple days, oftentimes you got to come clean. Now, we need to identify attacks, and then we need to do things to hasten recovery. And so we have protocols in our clinic. We check your urine to make sure you don't have a urinary tract infection, because a UTI can mimic an attack. If we don't find a UTI, then we can use lotions and potions to hasten your recovery from an attack. We can give steroids and IVIG and all kinds of sassy stuff to get you back faster. And if you're taking an MS medicine and you have a breakthrough attack, that's not okay. That's like being on a birth control pill and getting pregnant. It means it didn't work. And so if you are taking an MS medicine and have an attack, we're going to follow up later to talk about if that medicine is misbehaving or not. When we talk about living our very best life, when we set our life goals and then we move our attention to MS goals, when we operationalize MS goals, one of the things we need to do is we need to treat MS attacks. The second thing we need to do is we have to address chronic symptoms. So what are symptoms? Symptoms, simply put, are things that stink. So when you have an MS attack, and I'll give an example of a transverse myelitis where your leg feels like it's burning, and then we give you steroids, and over time your leg gets 95% better. When you get overheated or when you get tired or during your menstrual cycle, your leg burns. You now have a chronic symptom of a burning leg, right? So now you've kind of got stuck with a symptom. So I like to remind everyone, I have a pill for every ill. I'm not going to give you a pill for every ill because you don't like taking medicines and I don't like writing out all the prescriptions. But if something is bothering you enough, we need to address it. I'll use my absolute favorite example, erectile function. Did he just say erectile function during dinner? That's really weird. No, I'm being serious, erectile function. So men, we like our erections, it's true. And men with MS can develop difficulties with erection. That can happen. And if a gentleman with MS has erectile dysfunction and he doesn't like it, then I give him Viagra, right? I give him a little blue after dinner mint that makes Friday like really great. Now, if a gentleman with MS has erectile dysfunction and doesn't care, I don't care. Because treating erectile dysfunction doesn't speed up or slow down MS, it just makes Friday better. Is that therefore not important? Incorrect. It's very important because it gets to the quality of someone's life. So we have to attend to chronic symptoms if we're going to help you live your very best life despite having MS. If I slow your disease down, which I'll get to in a second once you start your main course, and you're miserable in the process, I didn't do my best job. In order to go home at night and feel proud, I need to slow the disease down and I need to treat chronic symptoms. So it turns out that there are constellations of symptoms that kind of hang together in MS. And I want to talk about a few of them with you today. Whenever I'm talking to patients, I always ask about invisible symptoms. Now, invisible symptoms are real, but other people can't easily see them. So, for example, I talk about the up theres. What's the up theres? Well, you know, the up theres. Thinking of memory, energy, mood, the up theres. So the up theres are tied together with a bow because if you're depressed, you won't think clearly. And if you're exhausted, you'll be more depressed. They're all tied together. And very frequently, people impacted by MS can have some difficulties with the up theres. 70% of people with MS have fatigue. More than 50% of people have impairment of thinking and memory at some point in their life. And over half of people impacted by MS experience a bout of depression. Those are very common symptoms. When dealing with the up theres, if I don't ask, I don't necessarily know, right? Because, honey, you look so good. Well, you don't look sick. Well, you don't look ill-informed, right? And so we have to recognize that this is a high risk. I mean, let's think about this. It's winter. It's getting cold outside. There's a global viral pandemic. OSU's not doing very well. You have multiple sclerosis. If you tell me that you're not feeling any bit of sadness, I'm going to wonder whether that's true or not, right? So my point is we have to dive in. And if we identify that someone has anxiety, if we identify that somebody is suffering from depression, if we identify that someone's not thinking clearly or that they have difficulties with energy, we dig in and we have to address those things to make them better. And we use lotions and potions to make them better. Now, sometimes the lotion and potion is a walk in the park, literally. Sometimes it's physical therapy. Sometimes it's talk therapy. Sometimes the pill is actually a pill. But the point is, I ask my patient to bring to my attention things that stink. And then I get very animated. I say, ooh, okay, I got all these ideas. We can do this and this and this and this. And then you're going to say, no, you're a weirdo, never, no, maybe. Say that again. And we're going to custom tailor what we do to help you. Okay, fine, I'll talk more about erections. As an example, if you give a gentleman Viagra and it doesn't work, our question becomes, how much do you care? Because we can keep going. We can do a shot on the side of them, and that will help. Or we can do an implant. My point is, if the symptom's bad enough, we're going to keep working on it until it's improved. Now, it's not just about the up there's. There's more going on. We have to think about the down there's. You know, the down there's. Bowel, bladder, bedroom. Be like, he's been talking about sex a lot. And so very commonly, people impacted by MS can have difficulties with the down there's, and that's an invisible symptom. If you would like to make an adult human miserable, make them have trouble controlling their bladder. It's horrible. And so we have to pay attention to those invisible symptoms. We have to work on that. There are other invisible symptoms, like pain. So I attended medical school not far from here, University of Cincinnati. And my professor stood up and said that MS does not cause pain, which was really weird because my Uncle Mark, who had MS, had a lot of pain. And so I stood up in class with 180 kids and I said, sir, I don't think that's right. I think MS causes pain. And he said, sit down. So he was wrong because MS can cause a tremendous amount of pain. In fact, there's a lot of very unique forms of pain that can occur in MS. Oftentimes, people don't even realize that it's MS related, like pathologic itching. Ever heard of pathologic itching? It's a terrible phenomenon where people have an itch and they can't resolve it by scratching, and they'll scratch themselves to the point of bleeding. It's a form of neuropathic pain. Now, I have been going over many of the things on Stuart's list, and nobody is playing bingo. Have we hit any of the words? We hit pain. Let's take a look and see if there's any others that we can check off. We did NMO, we did cognition. Oh, look at that. We did fatigue. We're doing lots of stuff. Let's talk very briefly about speech. All right, words matter, and in neurology, words matter. And people can have difficulties with speaking and swallowing in the setting of MS. And that's not an invisible symptom. That's a symptom that some people can see. There is not a pill for speaking, but there is a way to make it better. Anybody know the answer? Speech pathology. So a speech pathologist can retrain speaking and helping. And I'm going to move on and talk about what we do after we've operationalized treating an attack and treating necrotic symptoms. Now we have to turn our attention to slowing the disease down. And the way that I want to do that is by teaching you from treating an attack and treating symptoms to how we slow down the disease. And I want you to be 5 for 5 in your fight against MS. I'm aware of 5 things that slow down multiple sclerosis. So I want you to do all 5 of them. Number 1 is don't smoke stuff. Yeah, don't smoke stuff. Show of hands if you know that smoking speeds up MS by 50%. That's a terrifying statistic that I wish I didn't know, but it's true. If you smoke, you actually double your risk to develop MS. And so as a parent, I always want my patients to know that so they can be cognizant and make sure that their children aren't around a lot of secondhand smoke. And if you stop smoking, you slow down your MS. Now, I used to say don't smoke, but now I say don't smoke stuff. Why did I add the word stuff? Because of ganja, right? So because of marijuana. So here in the great state of Ohio, I am a medical marijuana recommender, but I don't recommend that you light it on fire and then suck in the smoke because that's super pro-inflammatory. It's pro-inflammatory to your lungs and to your blood vessels and to your brain. And it's as of a concern to me as if you were to smoke a cigarette. Now, the reality is that behind the discussion of don't smoke stuff is a very, very large discussion controlling other cardiovascular risk factors. If you want to live your best life despite having MS, we're going to need to go beyond just not smoking. We're going to have to pay attention to your blood pressure. Because if you have high blood pressure, you're going to end up more disabled at the end of your life with MS than if you don't. Same thing with high cholesterol. Same thing with morbid obesity. Same thing with excessive alcohol use. Same thing with under-controlled diabetes. All of these become terribly relevant if we want to live our best lives despite having MS. And so we start off with number 1, don't smoke. Number 2, exercise is part of your lifestyle. Really, Aaron? Let's talk about what do I mean when I say exercise is part of your lifestyle. Part of your lifestyle means that you don't get an award when you do it. And you don't have to go in the naughty corner when you don't. There's no reward. There's no punishment. It's literally just part of your lifestyle. I, for example, have a lifestyle of showering in the morning. It's just something I do. I don't tweet about it. I don't send out a Facebook post, had a great shower. I don't take pictures of selfies in the shower. I just shower. And he's so jealous. And if I didn't get a shower in the morning, I wouldn't feel downtrodden and call off work and sit at home and be upset. I would just shower that night, right? And so I need us to exercise as part of your lifestyle. The data is rather compelling. People impacted by MS who exercise as part of their lifestyle end up less disabled at the end of their lives. They handle spasticity better. They have better balance. They fall less often. But it goes beyond that. They have less depression and fatigue, and their cognition improves. But it goes beyond that. It actually slows the rate of brain volume loss. Exercise is arguably the most underappreciated disease-modifying therapy that exists. I want to tell you a story of a gentleman that I used to be able to take care of a while back. He's passed away now. He was my math teacher when I was in high school. And he became my patient with primary progressive MS in an era where there was no drugs to treat PPMS. And he was a really tall gentleman. I mean, I'm tall, but this guy was like 6'6" or 6'5". He was really tall. And he was getting to the point in his disability that he was having increasing trouble using a walker, and he was using his scooter and his wheelchair more and more. And he was really upset about it. And so we hashed a plan. We found a YMCA and a life jacket and a really crappy old walker. And he took the cruddy walker in the water with the life jacket, and he walked laps at the YMCA in Gahanna, Ohio. And he did that a couple times a week for 3 months. And then he came back to see me in clinic. And I'm in my office getting ready to see him, and my MA sticks her head and she goes, "Hey, Dr. B, your patient won't do his timed 25-foot walk until you come out and watch him." So, okay. So I stick my head out there, and it's him. And he's standing up with his walker, and he says, "Young man, are you ready?" And he picks up the damn walker, and he walks 25 feet holding the walker in his hands. Now, that man didn't have access to a medicine. None existed. He did that by sheer force of will through exercise. And it wasn't some airy-fairy story that I read. That was my patient that I had the honor of taking care of. And it just speaks to the fact that exercise makes a really big difference. Let me share it with you one other way, okay? Let's do a thought experiment where we clone you. So you have to get permission from your spouse, and they might not let us, but hypothetically, there's 2 of you now, okay? And we're going to give one of you an elliptical. I'm watching some spouses discuss whether it would be okay. That's awesome. They're like, "Is that all right?" No? Well, they could do the dishes. So we have one clone who gets chocolate cake and Days of Our Lives TV. And the other clone is going to get an elliptical and carrots, all right? And then we're going to get back together in like 2 years, right? The first clone has gained some weight, right? She's kind of out of shape. Balance is not so awesome. Cardiovascular endurance is non-existent, but she knows a lot about cake, and she knows everything there is to know about Days of Our Lives TV. The other clone lost the weight that the first one found. All right, she's got a strong core. Her balance is better than it used to be. Cardiovascular endurance has improved. She's more flexible. She's really in good shape. And then we're going to cast a Harry Potter magic wand spell. We're going to cause an attack of left leg weakness. Now, the first clone is stuck in a wheelchair looking up. The second clone is limping. And I'm not going to insult you and ask, quote, "Who do you want to be?" It's a rhetorical question. What I would rather do is point out that in the first example, we allowed her to become deconditioned. And when she had an attack, she couldn't overcome it. The other one, we prehabilitated. And so she's limping around being sassy pants, getting ready to go back to doing tennis. And we need to be exercising as part of our lifestyle if we're going to be able to do that. Now, let's talk a little bit about like what we could actually do to exercise, because it's real easy to talk about. It's hard to actually do it. When we exercise for MS, there are 4 areas that we want to focus on. Area number 1, cardiovascular endurance. Area number 2, core strengthening. I am not impressed by biceps and quadriceps. I'm impressed by your butt, hamstrings, your abs, and your rector spinae, your core. That's what's going to help you get up off the ground. That's what's going to help you not fall, right? Not your amazing forearms. We need to be thinking about flexibility. Flexibility is super important. And 70% of people impacted by MS have spasticity, and all of you live in Ohio, and it's really cold here, and so spasticity gets bad. Stretching is super, super important. So that's the third thing. Like the last one is balance, right? Balance is super important. And that old adage that you can't teach an old dog new tricks is false. And we can learn stuff, adult humans, and we can improve our balance through exercise. Now, that's all well and good, Aaron, but it's hard to go home and exercise after a hard day's work, and having MS makes it really hard to exercise sometimes. So let me give you some tricks and tips. Water is darn near magical in MS, right? Getting in water is magical because in the water you weigh less. And so if you have a weak leg, you can put more weight on that weak leg. You can walk maybe in the water when you couldn't walk on land. That opens up opportunities to exercise. If you have a problem with balance and you're leaning to the left, the water pushes back to the right. If you have a problem with heat sensitivity, many of my patients are heat sensitive. The water wicks the heat away from your body. Spasticity is decreased in the water. So water Zumba, water aerobics, swimming, walking, all those things are fair game. Another thing that I really like is yoga, right? So yoga is pretty cool because you can jump on YouTube and you can type in yoga and you'll find millions and millions of videos, and they're free, and you can do it, and all you need is a floor, right? And if you think about it, yoga, as an example, is going to help with flexibility and core strengthening, right? It's going to help with balance. So you're getting 3 of the 4 things, right? If you're still struggling to think about how you can engage in exercise with MS, my best trick and tip is the Dayton Rehab and Balance Center. All right, so there are some really, really smart neurophysical therapists in this town. And go see one of them and say, hey, I have MS, I'm trying to get back in the game. They will work with you and help you develop a home wellness program. Don't ever let a physical therapist show you an exercise without teaching you how to do that at home. Very important. So as we try to live our best life, despite having MS, as I want you to strive to be 5 for 5 in your fight, number 1 is to not smoke stuff, and number 2 is to exercise as part of your lifestyle. Number 3 is to eat smart. Eat smart. What's that mean? It means that what you put in your mouth matters. It means that allopathic doctors, I'm an allopathic doctor, we don't learn very much about nutrition. And you may, as a family surviving and thriving with MS, not have been talked to very much about nutrition. Show of hands if your clinician talks to you regularly about nutrition. So for those of you on the interwebs, only one person raised her hand. So let's fix that. All right, so there are a lot of things that can really, really impact MS as it relates to diet and nutrition. And let's go through 4 or 5 of them. Number 1, probably the very most important, is to up your water game. So many of us are dehydrated. And being dehydrated does horrible things to bowel and bladder. It increases UTIs and bladder spasms and pain. It increases constipation, which can make pain worse and can make spasticity worse. But being dehydrated goes beyond that because it can do other weird things like make fatigue in MS worse. It can make depression, I'm talking about water, in MS worse. I really need you to up your water game. If you're a boy, I want you to drink 120 ounces of water a day. What? If you're a lady, we're looking at 100 ounces of water a day. How do you do that? It's hard. First off, you need to find yourself a 20-ounce glass, right? That's your water glass. You put your name on it. I want you to have a glass of water with breakfast. I don't think that's asking too much of you. A glass of water with breakfast, please. Then I want you to have a glass of water with lunch. You see a trend? Then I want you to have a glass of water with dinner. So you just have a glass of water with each meal. I don't think that's asking very much. Just teach yourself to add a glass of water with each of your 3 meals. Once you master that, you're over halfway there. Now, I simply need you to drink 1 glass of water between breakfast and lunch. You eat breakfast at 7, you eat lunch at 1. You can drink 1 glass of water in those hours. Come on now. And then we're going to drink 1 glass between lunch and dinner, and then you're good. That's 100 ounces. If you're a boy, keep going. And so the reason I want you to drink water like that is because you make urine for 6 hours after you stop drinking something. So if you do what a lot of us do, we drink coffee or nothing during the day, and then we come home, and then we're really, really thirsty, so we start to pound water, and we're pounding water, and we're drinking water, and then we have water, and then we go to bed, and we put the water at the bedside table, we get in bed. Right? Sound like you? And then you wonder why you wake up 3, 4, 5 times a night to go wee-wee. It's because you're making urine all night long. So if you drink 2/3 of all the water in the first half of your day and kind of put the kibosh on water around dinner, That's the recipe for winning. If you make one change in nutrition for MS, I want you to up your water game. I'll tell you a secret. It'll make you lose a lot of weight because you're so full of water, you're not going to be all that hungry. Now, the second thing that we want to do if we're going to up our game and focus on nutrition and eat smart is supplement low levels of vitamin D. Now, many of you in the audience live in Dayton, Ohio, right? I live very close to Dayton, Ohio. And we share something, Columbus and Dayton. A complete lack of sun for like 5 months out of the year, right? It started yesterday. So we're going to not see the full sun for quite some time. MS Views and News, the group that is hosting this event this evening, they came in from Florida. And I wish they would bring their weather with them, right? Because they're winning and it's going to get colder and colder here. And we get vitamin D through the sun. And so when there's not a lot of sun, we're not getting a lot of vitamin D. And it turns out that low levels of vitamin D drive MS faster. You hear that? If you have a low level of vitamin D, it makes your MS get worse faster. Well, that's not a good idea. So there's a couple different ways to get vitamin D. One way is to go out shirtless in your backyard, or your front yard for that matter, for 15 minutes in full sun, right? And when the cops come, be like, no, Dr. Boster said I was supposed to. Now, if you do that, you'll absorb 5,000 international units of vitamin D. And let's be honest, that's super unrealistic. And so we can take a vitamin D supplement. And we can check a level to make sure that your blood level is above 50 but below 100. And that's when we up our game as it relates to vitamin D. Let me do one more as it relates to diet. And it's tough. It's the hardest one. It's to avoid processed foods, sugar-laden foods, fried foods, fast foods, diet foods, soda pop, and any food with ingredients that you can't pronounce. Because if you can't pronounce it, that's not a food, that's a chemical, and I don't want you to eat it. Now, that's a very hard request, but if you do it, you will very likely call me or send me a Twitter DM saying, oh my gosh, because something amazing happens. Your energy levels skyrocket, your depression plummets, you think more clearly, and you have better time at work. It's remarkable. And every once in a while, someone takes me up on it, so I double dog dare you to try it. If you want to live your best life despite having MS, I need you to be 5 for 5 in your fight. And number 3 is to eat smart. Number 4 is a daily practice of mindfulness. Show of hands if you're familiar with mindfulness. About half the audience raised their hand. I'm delighted to see that. Mindfulness is a concept that I had never heard of growing up. Like we didn't have like mindfulness training in elementary school. Mindfulness is something that in Western culture is kind of new in some respects, but that's really sad because it's super, super important. I define mindfulness as being in the present moment without judgment. So being in the present moment, not telling yourself a movie in your mind about what may happen tomorrow, not reminiscing and lamenting about things that happened in the past, being in the present moment. So if you're having sex and thinking about work, that's not being mindful, right? Because you're not actually in the moment. So think about that. So there's a lot of things that are beneficial if we practice mindfulness, and it's free. And so I have developed an opinion that people impacted by MS do a lot better in their lives if they practice mindfulness once a day. It turns out it's really easy to do, right? So I'll share with you, remember how I told you I have a lifestyle of showering? I do. I have a lifestyle of showering every morning. So I added something to my shower. When I'm done cleaning my body, I sit down on my shower floor, Indian style, and under the water, and I close my eyes and I meditate. What does that mean, I meditate? Well, I just sit there and I breathe, and I think a bunch of thoughts, and I just let them come and then let them go, and then I keep breathing. And after a few moments, I just kind of tune into my breathing. In the water, I can hear the water, and I can smell the water. I know that sounds weird. And I sit there, and I just focus on being in the moment and not worrying about clinic yet, not worrying about what I forgot to do yesterday. And I do that for 5-10 minutes. When I stand up, I feel energized. I feel massively empowered. It's really awesome. And I sometimes look forward to my shower because I really want to sit on the floor. Like, I wash really quickly so I can get in position. That's being mindful. There's other ways to be mindful. Mindful meals. Mindful meals are great. Turn off the TV. Like, notice who you get to eat with. Practice gratitude that it's delicious. Mindfulness is super duper important if we're going to live our best lives and attempt to be 5 for 5. The last thing we need to do is to take the most effective medicine that you're comfortable taking and make sure that it's working. And I'm talking about MS disease-modifying therapies. So, in my opinion, taking an MS disease-modifying therapy is like a diabetic taking insulin. We can't live our best life without adding medicine, in my opinion. Now, that doesn't make me right. It just makes me really, really opinionated. But I can defend my opinion with Class 1 evidence. And when my Uncle Mark was diagnosed with MS, there were no therapies. When he was fixed in a wheelchair, there were no therapies. He was stuck in a bed before the first therapy came out. He didn't have a chance. Today, as I stand here, there are 27 different formulations of FDA-approved medications to treat multiple sclerosis. That's amazing. And before we go on, we need to pause and thank a bunch of people with multiple sclerosis who volunteered the most precious thing they have, their bodies, so that we could develop 27 drugs to treat all the people that I get to treat. So can we give them a round of applause, people with MS that participate in trials? If it wasn't for those people, we would have no therapies to offer them. It would be just like when my family was struggling with my uncle's MS and we had nothing. Now we have all these things. And I'm not standing up here today saying that you have to take drug A or you should take drug B. Not at all. I want you to have an engaged conversation with your clinician. I want you to share your life goals with your doctor. I want you to have them discuss the goals of treatment. Then we need to figure out which medicines make sense. We need to talk about the good, the bad, and the ugly. The way I like to do it in clinic is I'll write up 5 drugs that I think are appropriate for you based on what I've learned in the order of efficacy, in my opinion, and then we talk about the first one. And if you don't like that, we downgrade the option to the next one. And if you don't like that, we downgrade the option to the next one. We get to the bottom, and you don't agree, I go get coffee, and we start up at the top again. I'm being serious. Now, please listen to my sentence very carefully. If you have to have MS, now's the best time ever because of the options we have to treat the disease. So there are increasingly options. There are now biosimilars and generic drugs coming on the market, making access to care all the easier. There is a lot that we can do. I have failed 0 times in 17 years getting someone on a therapy. The only people in my clinic that are on a therapy choose not to be. If you want to live your best life despite having MS, and you've set your life goals so that MS doesn't get to pick, you've clarified your MS goals so you and your team know what you're shooting for, you know your target, you are clear on how to treat an attack and what numbers to call and what's going to happen, and you're forthcoming with the symptoms that erode the quality of your life, then I need you to be 5 for 5 in your fight. I need you to not smoke stuff. Exercise is part of your lifestyle. I need you to eat smart. I want you to be mindful at least once a day. And I want you on the most effective drug that you're comfortable taking. That's my recipe for winning despite having this disease. Thank you so much for your attention tonight.
Thank you. Thank you, thank you. So, for everybody online, we apologize for the sound problems that we're having. It's this environment, okay? It was coming in tinny, it was coming in scratchy, it was coming in where you sounded like you were in a box. There was a lot of different things. We were playing with a lot of different things. We got it working, and that's the bottom line. We got it working, all right? And for everybody in attendance, what'd you think about this? Great. All right. Does anybody in the audience have any questions?
How does mindfulness actually improve your MS?
That's a really good question. There was a study that a friend of mine, a gal named Dr. Amy Sullivan, shared with me. So Dr. Sullivan is this brilliant gal up at the Cleveland Clinic in Cleveland. She runs their behavioral health center at the Mellon Center. And she's a very smart woman. She told me about this very disturbing paper that looked at stress and stressors. And what they found was people were more likely to have enhancing lesions. So it actually matters. And so the idea of being active, proactive, in trying to control stress and anxiety has a direct impact. Let me give you another example. Mindfulness is associated with happiness. Mindfulness is associated with decreased depression. Depression drives MS faster. Uncontrolled depression drives MS faster. I don't know what you're pointing us to. And so mindfulness can help decrease depression, and therefore slow the disease down? That's a great question. Thank you.
If you know someone that was recently diagnosed and they're attending, going to see their doctor maybe for the second time, what would be a good question for them to ask their physician?
That's a great question. So we first have to recognize that the relationship that the person with MS and the clinician has is intimate. It's an intimate relationship. Now, it's not like a sexual relationship, but it's intimate because you're gaming out how to live your best life. You're sharing things with them that you don't share with your priest or your spouse. I mean, you really talk about some serious stuff. And so I think that there has to be a degree of respect for that. And I like to know the people that I am intimately working with. So I may ask the doctor, can you tell me one thing about you that has nothing to do with medicine, please? Like, what do you like to do for fun? Or I might want to bring the doctor my list of questions written down to demonstrate to them that I've been thinking and that I thought what they said and to kind of help that really. Those are the kind of things that I want to do. You know, if you go to MS Views and News website, they have a downloadable form, which I love. And if you simply fill it out, it will prep you for your visit. So someone who is newly diagnosed and they're getting the hang of it, that's another very helpful tool, is to prepare themselves with a document like that so they feel ready to go and see the doc. Great question.
Hi, we're enjoying your presentation
Woo-hoo!
so much. Thanks for being here.
It's my pleasure.
So I was wondering, what are some of the best foods that you would recommend for patients with MS?
So to talk a little bit about food in MS, I shared earlier how I want the food to be real, whole, and single ingredient. So that's important. And when we talk about what kind of foods, the first thing I want to pay attention to is the macronutrients. All right, so I want to make sure that we get enough protein. We literally want a gram of protein for every 2.5 pounds of body weight. Right? So if you do some math, you know, you may need 70, 80, 100 grams of protein a day that you're going to divide between 2 or 3 meals. And I want you to eat your protein first. Protein is very, very important for skin integrity, to help prevent decubitus ulcers, for hair integrity, for a lot of other things. And it's also very satiating, right? And so from a body composition standpoint, from a diet standpoint, eating your protein first is going to set you up for success, right? I want to do that first. Now, what kind of protein do I want you to have? So if you're looking at various types of meats, right, lots of things are on the table. So there's a million kinds of lean cuts of beef and bison and pork and chicken, and fish is probably one of my favorite from a health standpoint as far as that's concerned. But you don't have to have meats. There's a lot of vegetarian options, whether you include eggs or not. That's a great way. Yogurt, cottage cheese. There's a million ways that you can get really, really solid sources of protein, and you want to make sure of that. And I want to do that first before I do any of the other stuff. The second thing I want to pay attention to is fiber. So fiber is an indigestible solid. It's like sawdust. So if you put it in here, it comes out there. And if you mix it with water, because we've upped your water game, it swells and makes a big, bulky stool that's easy to get rid of, easy to hold on to. Enjoy your dinner. And that's very, very important. And it's missing from most American diets. So fast food and processed food removes fiber because it makes it cook faster, right? But it's not as healthy for us. And so I want a gal to have 25 grams of fiber a day. A guy needs 38 grams of fiber a day. And so after you eat your protein, I want to make sure you get your fiber in. Now, fiber is oftentimes found in complex carbohydrates, and I'm okay with that, but I want you to avoid simple carbohydrates. I think sugar is actually a poison, and so we're not going to do that. Now, what about fat? Fat is not bad for you. Remember in med school when they said MS didn't hurt? They also said MS only involved white matter, right? And they also told me that fat was bad. They were wrong. And so there's a lot of healthy fats out there. And in MS, there's actually some evidence that omega-3 fatty acids may be helpful in multiple sclerosis. So like actually helping with the disease process. So omega-3s are a particular kind of fat that I'm really into, and you can get that through like fish oil or fatty fishes or supplements and things like that. So there's more that I could say, but that's where I'm going to start the conversation. And if you're following those guidelines and eating real food, you're crushing it. You're beating most red-blooded Americans and then some as far as eating smart. Great question.
Thank you much. Now we're over here for some virtuals.
Here we go.
The first one is from somebody named Machika, who's asking, NMO, what is it and how do I know if I have it?
So NMO is an inflammatory disease that affects the central nervous system. Like MS is an inflammatory disease that affects the central nervous system. But NMO is different than MS. The way that the disease occurs is actually different, the pathology. And it tends to hang out in the optic nerves in the spinal cord. Now, it's going to be very, very hard for a non-neurologist to ferret out if they have MS or NMO. And the way I think we do that is, number one, we get MRIs. Because there's certain features on the MRI that'll tell me, hey, this is more or less like NMO or more or less like MS. The second thing is blood tests. And so there are blood tests which you can use to test for NMO. And so we can send off the NMO antibody or the MOG antibody. I like to send those to the Mayo Clinic. I think they do a really, really good job. And lastly, if we're still confused, sometimes a spinal tap can be very helpful because we can see findings in MS, olive clonal bands, that we would not expect to see in NMO. And so those are the tools that I use to differentiate them.
Okay, thank you for that. And in follow-up to that, the next question is, are there any medications available for NMO?
Yes. Now, it's outside the context of this MS lecture, but there's been a revolution in NMO therapies. And so we now have 3 FDA-approved NMO therapies added to 1 or 2 that we were using off-label for years. So we can now do more than we've ever done in the past.
Great. Thank you for those answers. Next, we have Elisa asking, I have PPMS, taking Ocrevus for 4 years, but I still have progression. I already do the things you suggested. I don't smoke and etc. My exercise is limited to PT. Is there anything else I can do?
So thank you for writing in. There's not enough information for me to really be able to answer the question. I do hear something that I want to touch on, though. So she said, I have PPMS. I'm doing my part, Aaron. I'm 5 for 5. I'm taking Ocrevus, which is approved for PPMS. It slows it down. I'm doing the exercise piece. I'm not smoking stuff. And I'm still having progression of disability. And so let's talk about that. That's an unpleasant thing, but I think it's something we have to be honest about. So when you look at the clinical trials for primary progressive MS, and they give a group of people Ocrevus, and they give another group of people placebo. That's how we did the trial. It's called the Oratorio trial. And at the end of 2 years, we looked at the difference. The people on Ocrevus got worse. They progressed. But they progressed 25% less than the people that were on placebo. They both got worse at the end of 2 years, but the people on Ocrevus got less worse. So hypothetically, the person who asked the question, if we had cloned you, and we gave one of you Ocrevus and one of you a hug, 2 years later, I think you said 4 years later, both of you would have had some progression. But she who is on nothing would have had much more progression than she who did not. Now, I'm not proud of that answer. I'm just being honest.
Okay, thank you. By the way, if anybody has a question in this live audience, I'll be there in a minute. Just let me take a few of them from here. All right. Next, Renee asks, how long does it take to see results when starting Ocrevus? And what are the benefits when taking Ocrevus?
So let me broaden the question to, how do you know if an MS medicine's working? Right, that's an important question. So if you have a headache and you take an aspirin, within about 15 minutes, you know whether it's working or not because your head stops hurting. And frankly, most red-blooded Americans think all medicines kind of work that way. I take a medicine and then right away I'm doing better. Thank you. MS medicines are not like that. We don't take an MS medicine to make us feel better. Let me repeat that. We don't take an MS medicine to remove the symptoms we currently have. That's not why we take MS medicines. MS medicines are like birth control pills against future attacks or future spots. So if you have 3 children and you start oral birth control, you still have 3 children. They didn't go away because you started birth control. And my joke is, if you want to know why you're on birth control, go hang out with your 3 kids. It's because you don't want an unplanned event. You don't want an unplanned pregnancy. So when we're assessing whether a disease-modifying therapy is working, we're really looking for the absence of things. We're looking for the absence of progression of disability. We're looking for the absence of attacks and the absence of new spots. So that's really one of the major ways that we're trying to assess whether or not a given therapy is working, is if we're seeing disease activity clinically, which is not okay, or radiographically, which is not okay.
Okay, thank you. Next question, few different people asked similar question about smoking. So I'm going to break it down to this. Does growing up in a household where people smoked while you were a baby add to a possibility of you getting MS?
Yes, it nearly doubles your risk.
Okay, thank you for that. Next, I'm going to ask a person named Cheryl asks if you have an interstate medical license.
So that's a great question. So the question is, do I have an interstate medical license? I don't, because Ohio doesn't make that available yet. So there is a movement in the United States, which actually preceded the pandemic, but it's been accelerated because of the pandemic, to figure out a way that doctors can treat across state lines. And so there's this compact license or this interstate license which has been developed, and I'm very eager for Ohio to accept that so that I can take advantage. But as of right now, that's not an option for an Ohio physician.
Okay, the next one has to do with intermittent fasting.
Haha.
And they want to know what you can tell them of why the benefit of intermittent fasting.
Show of hands if you've ever heard of intermittent fasting. So a lot of you have. So I got fat, right? I got fat. I'm a pretty short guy. I weighed nearly 200 pounds. Whew. And I decided that I really needed to lose weight. And the reason that I finally decided I needed to lose weight was I couldn't fit in any of my clothes. So I either A, needed to make a bunch more money and buy all new clothes, or B, I needed to lose weight so I could fit into my clothes. So I really needed to lose weight badly or go to work naked. And I did what I was taught in med school. I tried to exercise, which didn't go very well, and I tried to stop eating stuff, and I gained weight. It made me really mad. So I sat down, pissed off at the computer, and typed in, "How do doctors lose weight?" Enter. And intermittent fasting came up. And so there's this amazing nephrologist named Jason Fung. I've never met him, but I'd give him a hug. And he wrote this really cool book called The Obesity Code. And I read it, and I learned that at University of Cincinnati, they taught me a lot of stuff incorrectly. And so I learned about intermittent fasting, and I lost 40 pounds. And I've kept it off for like nearly a year. And it's really cool. So let me explain very briefly how it works. It's a biohack. When you eat a piece of food, your sugar levels rise, and then your insulin levels rise. Insulin is the storage hormone. So when your insulin level is up, it tells your body, any subsequent energy you bring in, store it. We're good. We don't need to use it right now. Just stick it away for later. And when your insulin is elevated, you cannot tap into fat burning. You cannot burn your own fat. That's shut off. So if you eat something and then a little while later eat something else, if you are currently running, you'll burn it as fuel. If you're sitting, you'll stick it on your belly. I was sitting. And so when you reflect on the way that I was eating, I would wake up in the morning, 5:30 or so, milk in my coffee, spike in my insulin, more coffee, spike in my insulin with milk, cream, Go to work, I'm not going to have breakfast as I eat a Danish. That's not breakfast. I'm standing. And then I would have a little nosh, a little bagel somebody brought, but I'm not eating anything. And then I'm going to skip lunch. I don't need to eat lunch. I'm busy working. But I will cram half a sandwich in my face around 3 and not tell anybody. And then when I go home after giving a lecture that evening, I am crazy hungry. And it's my house and it's my refrigerator and I bought all the food and you have no business to tell me that I can't eat all the stuff in the refrigerator. And I would sit there and embarrassingly eat out of the refrigerator. And then I'd go to bed at midnight. I never let my insulin level fall, ever. I kept it elevated all the time. So what I do now is really simple. I start eating at noon. I stop eating at 8. And then I don't eat from 8 until noon. Now, it's a little more complicated than that. But what that does is it allows my insulin level to fall. So for the first 6 to 8 hours, I'm burning the sugar that I've been eating. And then when all the sugar's gone, I'm either going to die because there's no energy or I'll tap into fat burning. And then I wake up in the morning, I don't eat breakfast. So I'm burning fat all morning. I'm burning. And then I finally break my fast at noon. That's intermittent fasting. And for me, it's been really great. And it turns out that it's safe in multiple sclerosis. This has been studied in MS. My favorite study about intermittent fasting in MS was a study done out of Saudi Arabia. So a lot of people in Saudi Arabia, they are Muslim. And there's a very, very important holiday where they fast while it's light out for a month. So in Ramadan, so when the light's out, they don't eat, drink, smoke, nothing until it's pitch black. And so for thousands of years, a whole group of people have been intermittent fasting. And many of them have MS, and they reported on it, and there was no new attacks, there was no progression of disability. It was safe, which is really cool. Now, I want to fast forward and share with you, I think this is the best way for someone who has trouble moving to lose weight. My Uncle Mark was a heavy guy. He was really heavy. And he barely ate anything. He couldn't burn calories because he just sat there. I have helped people in wheelchairs lose 30 and 40 pounds, which is really exciting. And some of them can't move very well, but they did it through fasting. This is neat. Thanks for asking the question.
Thank you.
Dr. Boster, when do you consider Mavenclad for a patient? I don't know a lot about it, but it sounds attractive that you go through a treatment and then you don't need any meds for a long time. So what more can you tell us?
So let's talk about the way these MS drugs work. All right? So all the MS drugs try to prevent naughty white blood cells from leaving the bloodstream, crossing the blood-brain barrier, and attacking the brain. So all the drugs try to jack that up somehow. Most of the drugs block cells. So the cells can't get through. So for example, Tysabri and the interferons do that. They block the white blood cells from entering into the central compartment. Some of the drugs try to trick your brain and your immune system into not caring, like Copaxone. Or they hide the cells elsewhere, like in your lymph nodes, like Gilenya and those kind of medications. Or they suppress part of your immune response, which is one of the best ways of affecting MS. But there's another way to do this, which is different than all of that, and that's to reboot the immune response. So there are 3 FDA-approved therapies, cladribine tablets, Mavenclad is one of them, which work differently. They don't block, they don't murder, they don't trick. What they do is they reboot the immune system. And the way they do that is really weird and kind of neat, where they'll bring your cells down, and when they come back up, they come back differently. And so that doesn't make that better or worse, it's different. And some patients, they think that's amazing, and they're very excited about it. They'll accept upfront risk and upfront complexity in exchange for not having to take something on a regular basis. Other people would rather be jumped in a gang than to do that. And so it really becomes a discussion with your clinician, what's right for you.
My understanding of the neural reserve is that as people age, it diminishes. It also diminishes with MS. So how do you differentiate which is which, and does it matter?
Well-stated question. So what she's sharing is this concept of functional reserve. Show of hands if you're familiar with functional reserve. So some of you are. Let me explain what I mean when I say the word functional reserve. Functional reserve is your nervous system's ability to withstand an insult. Not an insult like you're ugly, an insult like you have a fever, or you have COVID, right? Or you have some other type of infection, or you're under significant psychosocial stressor. God forbid the house is burning down, something like this, right? I just forgot my point. What was I talking about? I'll come back on. Oh, I remember. So, yeah, thank you. I was talking about reserve, and I completely lost my neuro reserve. Thank you so much for helping me. You're right. As we age, our functional reserve shrinks. So when I was 18, I could skip a night of sleep. Now, as I approach 50, saying that makes me exhausted. In the setting of MS, the functional reserve can diminish upwards of 10 times faster than the general population. And so the question is, how do we tell the difference between decreased functional reserve because I'm getting older and the fact that I have MS? And the answer is, I can't. Not always. I can't always sort out the differences. And her second question is, does it matter? I don't think it matters as long as we look at all the modifiable things and adjust them. I'll give you an example. If you don't have MS and you exercise, you slow brain volume loss. If you have MS and you exercise, you also slow brain volume loss. So in both cases, it's really helpful to exercise. It's just more helpful in the setting of MS.
Awesome response.
Except for the part where I forgot about functional reserve. That was hilarious.
Okay, earlier you mentioned it's not a good idea to smoke. What about snuff?
So he asks about other tobacco products. So I said, don't smoke. He said, well, what about if I just cram tobacco in my mouth? I'm not going to kiss you after you do that. But there isn't a lot of data about whether or not that can hurt MS. We don't really know the answer. Now, because we don't know the answer, I'm going to vote for maybe we shouldn't, but I can't prove that. Because the research that's been done, which was mostly done with American GIs, was with cigarettes. Good question.
You described in DMTs similar to caring for diabetics. However, diabetics type 2 can withdraw from diabetic medication with the top of your described. Is there a chance the top 4 can also improve MS?
So thank you for wanting to spar with me. The person said, well, gosh, Aaron, you said that MS medicines is like insulin for a diabetic and that you can get off that. No, I'm talking about type 1 diabetes, insulin-dependent diabetes. So I'm not making an analogy to type 2 diabetes. But what I do want to say is that as we live our best life, sometimes we can drop things. Not medicines like disease-modifying therapies, but symptomatic medicines. I've seen many times when things are going really well, we can lose an energy pill, or we can actually improve things with bladder. So those things can happen.
Thank you. Next from Cindy, how do Ocrevus and BTK1 also work on B cells directly through microglia? Okay.
So one of the things I love about the greater MS community is, as a whole, you have your fingers on the pulse of this condition. It's really awesome. It's a group of people that are very, very motivated. It makes it super fun for me as I get to work with you. And so that's a very high-end neuroimmunology question that I was just asked. There's a drug, there's actually several drugs that deplete B cells. That's how they work, right? They work by going in and finding B cells and smushing them. Because if you decrease the B cells by murder, then the B cells can't make the T cells mad enough to attack you. It's a really cool mechanism. And so there are MS drugs, some of the most effective MS drugs that I've used, things like rituximab, ocrelizumab, ufatumumab. These are MS medicines that work by depleting B cells. Very effective. But there's an increased risk of infection when you deplete B cells. So there's a drug that we're developing. This is a new and emerging drug. Look at your bingo list. And it's called a Bruton tyrosine kinase inhibitor, or BTK inhibitor for short. Now, these are molecules that have actually been used in cancer for some time. They're not brand new molecules, they're just new in MS. And the way they work helps MS a lot, it appears, in a really weird set of ways. Weird way number one, it blocks B cell signaling without murder. Right? So you just plug the B cell's ears, la, 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 I can't hear you, and you don't murder the cell. So it doesn't really increase the risk of infection, which is pretty clever. Second, BTK inhibitors, for the first time really, can do something that none of the other medicines have ever been able to do yet. And that's to get in the brain to a part of the immune system we've never been able to touch, a part of the brain called part of the immune system called the innate immune system. And there's an innate immune cell called microglia that we've known about forever. And in MS, the microglia turn on, and they're kind of like the Incredible Hulk. They go bust things up and eat things they're not supposed to, like your brain. And we've never been able to turn them off. Well, BTK inhibitors turn them off. And so it's very exciting right now that we're studying this pill that you take once or twice a day to see if it can be the next best thing in MS. That's a great question.
Great. Next, thank you. I'm going to combine a bunch of them. You ready?
Do it.
All right. All about aging in MS for relapse remitting, progressive, all different forms. Also, when is best to, should people over 65 get MRIs? Should people over 65 continue to get DMT therapies? And why are people over 65 not being used for clinical trials?
Great set of questions. All right. So people are typically diagnosed with MS around age 30. So when I first got involved in MS care, people with MS were older than me. And then, after a while, they were my age. Now, they're like really young when they're diagnosed, around 30. But you don't have MS for just your 30s. You have MS until you die. So you have MS in your 40s and 50s, and then 60s and 70s and 80s and 90s. And as the person in the back of the room asked, you know, people as they age, they can forget stuff. You know, people as they age, they can have increased problems with doing things. People as they age, they can have a smaller function reserve. How do we sort that? That's really, really hard. And aging in MS is a really large growing area, right? So we don't have all the answers. The jury's out on a lot of this. And I have strong opinions, but unless you run out of the room, you're going to hear my opinion. I am of the opinion that we should treat people impacted by MS as long as they have nervous functions they like. So if you like seeing or swallowing or peeing or orgasming or moving your hand, or those are all nervous functions. And if you have some of those that you like, I want to do things to keep them working. Like I want to do things to help you keep them functioning. And if you have an immune system that would like to attack that stuff, I'm going to try to prevent that from happening. Now, I don't think you should do that after you die. So I'm going to stop therapy upon death. But leading up to that, I still want to treat you. Now, there's an argument amongst MS neurologists, like nerd fights, because there are some MS neurologists that incorrectly think that after you've achieved age 55 or something, that we don't need to treat you anymore. Why? Well, they're trying to be all highfalutin. They're saying, well, as the immune system ages, then it slows down, and we haven't really tested the medicines, and so maybe we don't need to treat you, which I think, to use appropriate language, is bullshit. Because the data doesn't support that. When you take a group of 55-year-olds that have had no disease activity for 5 years, and you take them off their medicines and watch them for 2 years, only 1/3 progress in disability. 2/3 had nothing bad happen to them. But if that 1/3 is my mother, not okay. And so I'm of the opinion that we shouldn't be ageist when it comes to age and MS. Now, whereas I don't want to stop your therapy, I will de-escalate your therapy. So de-escalation is where I still use an MS therapy, but I might use one that has a nicer side effect profile, something a little more easy to handle, maybe even a little bit less effective in certain areas because of where we are in the disease looking at that risk benefit. Another question asked was, do we need to keep imaging people after 65? So again, the jury's out. My personal practice, I want a brain MRI every year until about 60. And then after 60, it's a discussion. And typically we get a scan about every other year. Because statistically, the likelihood that you have new stuff is a little less. Now, if you say, well, Aaron, I don't like that, I want to get it every year, okay. But oftentimes, I think I can start to back off a little bit. That's just my own personal style. This is a very, very important topic, and it's going to become more and more important. Before we take another question, why don't we study older people over 55, that's not old, but people in clinical trials, and there's a reason. Money, right? So money, it's very, very expensive to do a clinical trial. And when they do a clinical trial, they're spending a bunch of money so they can demonstrate an effect. And if you enroll people that are young, like chronological age young, they haven't had MS for very long, and they're walking, you're more likely to see change over time compared to someone who's had MS for 20 years, or who is 60, or who is at a given point in their condition, say, using a walker. And so it's not that they don't want to study that, but you would have to enroll like 2 or 3 times the number of people to see small changes. And so statistically, it's not in their favor to do that. That doesn't make it okay, but that's the truth as to why.
I would think these days that with the age range having changed for MS, those that could have been used in clinical trials when they're in their 40s are easily in their 60s or 70s these days, and there's enough of them, people, to do clinical trials.
So it's interesting you say that. So there are some changes that are occurring. So number one, there are MS registries. We do MS registries at the Boster Center, and there's no age limit. I want to learn from you if you're willing to share. Also, there are some clinical trials that we are starting to participate in that are looking at going out to age 58 and to age 60. And that's revolutionary. And you say, that's not old enough. I agree, but that's a step in the right direction. One of the trials that I'm picking up goes up to age 60 and enrolls and follows you for 10 years. And so there are some investigations that are trying to look farther down the line.
It's great to know. Thank you. All right. One of the people that asked one of the questions of the several that I just gave you is from Germany, and she wanted to let everybody know she's from Germany watching, and she loves you. Okay.
I love you back. Thank you very much.
Another
you
one
stayed
of-
up really late tonight. Thank you.
She is. She's up in the middle of the night watching. All right. Another one of her questions, so she could go to sleep, is there a way of testing for MS progression or biomarkers other than using MRIs?
So how can we measure this disease and track it? Like, what are the ways that we can track it? So I'll answer the question what we can do today and then what we can do like tomorrow, right? So today we use 3 things to figure out how you're doing. The most important is what you tell me because you're a you expert. And if I listen carefully, you'll actually tell me the answer. So I don't just mean attack, no attack, cane, no cane. I mean like I'm not going to church because it's too far to walk. So I'm just going to stay at home. That kind of pulling away from the litmus test of life, I can learn that if I talk with you about it. So what you tell me is probably the most useful. And at least at my center, we kick it up a notch, and we have people fill out questionnaires which are created to really ferret out mood, energy, all kinds of different aspects of your life that I want to hear about. So that's one way that we do it. A second way is the MS Olympics. So when they make you do the tightrope, they're not trying to tease you. They're looking at your neurological functioning to see if it's gotten worse. So that's a way they can measure. That's a biomarker. The third way is the MRI. And we look not just at the white spots and the enhancing spots, we look at the dark spots and we look at brain shrinkage. And humbly, that's kind of what's available today, right? But there's a couple things that are right around the pike that are extremely exciting. And the most exciting, I think, is a blood test called neurofilament light chain. Show of hands if you've heard of neurofilament light chain. So let me share with you a little bit more about it. When you think about the brain, the cells in the brain that we talk about in MS are called neurons, right? So that's the nerve cells. And they're kind of like long straws. And if you crack one in half, all the stuff inside dumps out, right? And inside that long neuron, that axon, are a bunch of chains. There are light chains, medium chains, and heavy chains. It turns out that they go in the bloodstream and they float around the bloodstream, and so you can measure them. And it turns out that when you have MS, the neurofilament light chain goes up because you have loss of axons. And it's really interesting that it actually correlates with disease activity. So you could put someone on a therapy and you can watch their neurofilament light chain go from really high down a little bit. If you put them on a better therapy, it goes down to normal. If that therapy stops working, the neurofilament light chain starts to rise. Before an attack, it starts to rise. It's really exciting. It's not prime time yet, but it will be soon. And I really think it's going to change a lot about how we manage multiple sclerosis. I still think we'll get MRIs, but this is going to be one heck of an addition.
Hello, I have primary progressive. I am 75 years old, and I have a question because right now there are no therapies for me. I have also breast cancer, so I'm afraid to take the Ocrevus. Recommendations, please.
First of all, it's nice to see you. Thank you for coming to listen to me, and thank you for asking the question. I don't have enough information, so I'm not going to be able to give you a real answer here. What I'll share with you is she describes a situation with primary progressive MS. There's only one therapy that has been proven to work in PPMS. Now, when we studied that therapy, 6 women developed breast cancer, which made everyone, including myself, go, whoa, Scooter, because a lot of people with MS have breasts. So that's a big deal. Now, we fast forward 7 years, and there's been over 250,000 people that have been on this drug, Ocrevus. And we now know with authority that the risk of breast cancer is the same as the general population. Am I telling you that makes it safe? No. But what I am telling you is a story about 2 women that I take care of that have primary progressive MS. Both are breast cancer survivors, a little bit different. And both of them took the package insert to their oncologist to say, may I take this? And both of them said yes. And so the first thing that I would do is I would go back and ask, are you sure? But I can't really share more than that because I don't have enough information. Thank you for coming.
Thank you. Next, is it typical that MS patients get uveitis?
So uveitis is a Scrabble word, right? It's got a bunch of weird letters in it, and it basically means that the front of your eye gets all inflamed. And uveitis can be an autoimmune thing. And in fact, uveitis increases the risk to develop MS. But it doesn't mean that if you have uveitis, you're going to get MS, and it doesn't mean if you have MS that you're going to get uveitis. So they are seen together more frequently, but it's not a foregone conclusion.
Okay, next.
And there are drops that make it better.
Thank you. Person writes that they're drinking 4 to 5, 16 ounces of water per day. They want to start probiotics. They want to know how long before it's working and if you're going to stop pooping.
So are you guys familiar with probiotics? Yeah, so I think everyone with MS should take probiotics. I actually probably think most humans should take probiotics, but I certainly recommend it to the people that I take care of in my clinic. Let me explain why. So this is weird, but there are more bacteria inside your body than human cells, which is a very disturbing thing. You're more bacteria than human. And the vast majority of those bacteria live in your gut. They literally line your colon, right? So your gut's 27 feet long, which is really long, and it's full of bacteria. And those bacteria work to help break down your food for you. Like they help you process your food. They're like little factories. And that's called the microbiome. That's the name of all the bacteria that live in your gut. It turns out, for reasons that are unclear, that people with MS have an abnormal microbiome. They have dysbiosis, is a fancy Scrabble word for like it's the wrong bacteria. And we think that may actually impact the immune system, but we don't understand it well enough to act on it. But what it definitely does is create IBS and constipation and diarrhea and make my patients miserable. So what I have found is if you increase your water game and increase your fiber game, then you can hold on to big bulky stool easier and you can get rid of it easier. But sometimes that's not enough. Adding probiotics is a game changer for many, many of my patients, where if they're typically constipated, it kind of pulls them to the center. And if they're typically dealing with diarrhea, it pulls them to the center. And what you're doing is that pill has like 6 billion healthy bacteria in it, and you swallow it, and you just introduce the bacteria into your colon. Now, separate from probiotics, there's ongoing research looking at adjusting the microbiome to help MS, but we're not there yet. That's still ongoing research. Great question. Will it make you stop pooping? No.
All right, the next one is from a few people that are talking about symptom management of leg tightness. They're also asking about, hang on one second, it was leg tightness, what you could do for it, and how do you help somebody to exercise more on their legs if they're suffering with extreme pain when they try to?
Sure. So spasticity is very common in MS. About 70% of people with MS will experience spasticity at some point. Spasticity is a situation where your muscles are no longer cooperating. So if you think about my arm, and I want to bring my hand to my face, my massive bicep has to contract. It has to shorten, like so that my arm goes like this, right? And my massive tricep has to relax. It has to let go so that my arm can go this way. I don't tell my tricep to relax. I just say, iced tea, right? And my spinal cord turns off my tricep for me, right? So that's kind of a symphony. When you have MS and it causes damage to the brain and spinal cord, and you want to bring your arm like this, sometimes the tricep did not get the email. And so it thinks it's still supposed to do that. Now you have a tug of war with your own freaking limb, right? And that manifests as spasms, which is a bouncing, cramps, which is like a visible contraction of a muscle belly, like a Charlie horse, it'll drop a guy, and stiff limbs that make it really hard to get in and out of the car. Spasticity is worse under two conditions. When you're still, like sitting here listening to me or typing at your computer or sleeping or driving, you're still, and when it's cold outside. So waking up tomorrow morning in Dayton, Ohio, you're going to be spastic, right? And it can be very, very painful. So what do you do about stiff limbs? So pick a number between 3 and 8. Somebody shout out. 6. All right, let's do 6 things to make spasticity better. You're like, why didn't I pick 2? Yeah. So number 1 is to get your stretch on. I want you, when you wake up in the morning before you exit your bedroom, to stretch for like 5 minutes. You don't have to do it very long. Get on the floor and stretch out your butt and your back and your hamstrings and your hips and your quads and your calves. Hold each position for 30 seconds. Do it 2 or 3 times. And it's going to diminish your spasticity big time for hours, and it's free. Then, when you enter your bedroom at night, before you climb into your bed, repeat it once. It'll cut down on waking up with spasms and cramps big time. I only need you to exercise once more in the middle of the day by stretching just in the middle. Did you notice I just snuck in some exercise into your life? That was sneaky. So I want you to stretch when you wake up, when you go to bed, and then once in the middle of your day. Right? What else can we do? Up your water game. Serious. If you want to decrease spasticity, be hydrated. What's another one? Supplements, magnesium oxide, over the counter, 400 twice a day, easy breezy CoverGirl. That can help a whole lot. What else can you do? You can figure out how long you can sit before you get stiff. So do an experiment. You're sitting working, say, can I go an hour without having spasms? Nope. So if the answer is nope, at the top of every hour, get up, do a lap, sit back down. Get up, do a lap, sit back down. All right, figure out how long you can go. Number next, I don't know what number we're on. When you're driving from Cincinnati to come see me in Columbus, it's 2 hours. You might not be able to drive the whole way and get out of the car and walk. You may need to stop at Washington Courthouse halfway through, get up, walk around your car once, get back in your car and finish the drive. That can make a world of difference. How many was that? 5. So I said I would do 6? So there's a lot of medicines, but let's not do medicines. Let's do cannabis. That's more fun. So cannabis can help with spasticity, all right? Cannabis has lots of different chemicals, including THC and CBD. Both separately can help with spasticity. And so for those of you that are disinclined to mess around with THC, CBD, which is not a controlled substance and doesn't make you feel medicated, we can apply it topically and decrease spasticity that way. My patients do that a lot. That's 6.
Perfect. MS patient advocate Scott in South Dakota would like to know, what is active secondary progressive?
It's a bunch of neurologists goofing around with words. So there's 2 kinds of MS. There's relapsing MS and there's progressive MS, period. Relapsing MS has different flavors to it. The first attack, we call that clinically isolated syndrome because we have to make up words for everything. And then if you've had more than one attack, that's a relapsing form of MS. If you've had MS and you've had relapses, but you haven't had relapses in a while, and you're starting to develop disability separate from that, then you may have what we call secondary progressive MS, right? And I don't like that term because nobody appropriately understands it. And people have the misconception that it means drugs don't work, which is false, or that you can't receive treatment, which is false. They think you can't have attacks, which is false. It just means that you're going to have more progression than before, right? And so I think that's an important thing to keep in mind. Now, active secondary progressive MS is when someone has secondary progressive MS and then they have an attack or they have a new spot. It's really neurologists messing around with words so that they can enroll patients in clinical trials.
2 or 3 more questions, and that's it, okay? Your thoughts on HSCT, and please describe what HSCT stands for.
So remember I was talking about different ways of treating MS, and I said, like, you have cells that leave the bloodstream, cross the blood-brain barrier, get in the brain, and you're trying to do something to stop that. So there's a way to do that by rebooting the immune system. I talked about that. I said there are 3 drugs that can kind of reboot the immune system. And when we do that, I think of that as a soft reboot. It's like hitting restart on your computer and like letting it reboot. But you can do a hard reboot. So a hard reboot is when you open up the computer and remove the motherboard and then get a different motherboard and stick a different motherboard in there. That's a hard reboot. And that's a stem cell transplant. So stem cell transplants are not a drug, they're a procedure. I want to tell you something that most people don't know. The stem cells are not what make you better in MS. They keep you from dying. The way that we treat is the conditioning regimen. So the way that you do a stem cell transplant is they take out your cells and put them on ice, and then they give you lethal doses of chemotherapy. They ablate your immune system. And the more aggressive, the better it works for MS. And then, before you die, God forbid, they give you back immune cells so that you can repopulate and live. It's not prime time. Right? It sounds sexy, like I'll just go to Mexico and get my stem cells and then I'll be fixed. But it's not that straightforward. And it's not prime time yet. We're studying it. So our friends at the Cleveland Clinic, they're doing some clinical trials. There's a lot of investigations going on. I strongly don't endorse doing a stem cell transplant outside of a clinical trial, in my opinion.
And you can tell them why? What if they get sick?
There's a million reasons.
How they're going to be treated?
I'll give you an example. There's one of the most developed clinics for this is in Mexico, and when you're finished, then you're done. They say go find a doctor and go take Rituxan, and that's tough. I mean, so I have received a lot of patients that have had stem cell transplants. Some of them have done amazing. Some of them have done really good, but they still need care. It's not a cure. And so I think you have to be thoughtful about that. Having a stem cell transplant is a very serious thing to do.
Thank you. All right, person asks, if you can't take Ritalin, amantadine, or Adderall for fatigue, what else is there?
A million things. So MS fatigue is very, very common, all right? And so let's do it again. 5 through 10, pick a number. That you guys have all figured out. All right, 2, 1, I need to go home. All right, so let's do 4. So 4 things that can do. So B complex, right? Every B vitamin can improve energy except folate, right? Levocarnitine, CoQ10, creatine, and Provigil. Oh, oops, I did 5 by accident. Okay. I'm ready for the last question.
Good. All right. I've been on, and this is going to be a messed up word, I've been on cyclophosphamide.
Cyclophosphamide, Cytoxin.
Okay. To treat my MS for about 18 years, and it's no longer safe to have more infusions. I've now switched to Aubagio, but not very confident it can help suppress attacks as well as the cyclo. I'm JC positive. Are there other DMDs or treatments you would recommend? My MS was considered aggressive before cyclo. What can you tell me?
So that question makes me smile for a weird reason, because it reminds me of my mentor. So I was trained by a man named Omar Khan, who passed away several years ago. And the first thing he taught me was how to use cyclophosphamide chemotherapy to treat aggressive MS. This is before we had monoclonal antibodies. I just dated myself. And so this person has received Cytoxin, which is chemo, like chemo on TV, to treat their MS. And it's an extremely effective way of treating MS. My very first research paper I ever published was on Cytoxin and MS. And what they're saying is that they've been on it for a long time and they can't take it anymore. And so now they've been put on Aubagio, which I actually think is brilliant. Remember I said earlier that I don't want to stop medicines when you get older, but I want to de-escalate? That is a perfect example of de-escalation. Now, Aubagio in specific is not amazing at decreasing relapses and decreasing new MRI spots. It's good at it. It's not great at it. But it's great at slowing disability progression and brain volume loss. And in the second half of the disease, that's much more concerning to me. So I actually think that makes a lot of sense. I kind of like that idea.
Great, fabulous. And now I'm going to say thank you. And everybody here? Thank you, thank you. Let's all thank Dr. Boster again for everything he does. Everybody online can't see him right now, but he's up taking a bow and et cetera. All right? So I am going to say good night. Thank you.